Very good morning, friends. I must thank Sanjay for inviting me to London to participate in this wonderful conference, and happy to be here. I come from New Delhi and I work in AIMS, which is a large 2,000 and more bedded teaching hospital in New Delhi, and I bring greetings from you from there. So these are my case mix disclosures over the last 10 years, but over the last 5 years, it's more like 60% sleeves. I think it's not coming. It's 60% sleeves, 20% RYGB, and 20% OAGB. That's roughly the percentages. And coming to my talk, we just listened to Dimitri, and we know that sleeve, which was initially began as a staged operation for super obesity, and then as a primary operation for morbid obesity, was just thought of as a restrictive operation. The diabetic patients are a no-no for sleeve gastrectomy. But over the years, we've learned that sleeve has metabolic effects. And this is one of our own publications in 2016, where we looked at 20 class 1 obese diabetics, in which we did a sleeve gastrectomy. And we looked at some of the mechanisms and how sleeve is working. So if you look at gastric emptying, this is the pre-op gastric emptying in minutes, which has come down to almost half at various intervals after surgery. And more importantly, if you look at the GLP-1 values, we all know in the first phase, insulin response is blunted after surgery. So if you look at this preoperative graph, it is blunted, and after surgery, there's a sharp rise in the initial post-meal response to GLP-1 response to the meals. And correspondingly, there was again an insulin rise following the peak in the GLP-1. And this was seen at 3 and 6 months following surgery. So clearly showing that sleeve, because of its faster emptying, the food presents early to the digital intestine, and there is rise in GLP-1, which is partly responsible for the metabolic effect of sleeve gastrectomy. And again, we all know the other hormones like ghrelin, PYY all show a favorable response following sleeve gastrectomy. So this is what broadly shows that this is how roughly the sleeve works. Obviously, there are other mechanisms, and there might be weight loss or may be a factor, but these are weight loss independent mechanisms which could be responsible. Now, if you look at these papers, these have been quoted yesterday also. This is the SM-BOSS trial, which looked at weight loss following sleeve and bypass in a randomized way, and they looked at impact on diabetes. But if you look at the number of diabetics, it's fairly small. And but it still showed a comparable remission between the two procedures, which was not, and the difference was not statistically significant. And again, the sleeve bypass trial showing the response on impact on diabetes at various intervals. Sorry for this: 6 months, 1 year, 3 year, and 5 year. And if you look at the 5-year data, roughly 37% of the sleeve patients showed complete or partial remission, and about 45% of the bypass patients showed complete or partial remission. Again, the difference was not statistically significant. However, about a caution here, both these trials are not powered to look at diabetes in this randomized trial. So we have to take these results in that fashion. But this is again a very recent review by which is published in Obesity Surgery, which has looked at more than 2,000 patients compared with more than 10,000 bypass patients, in which they included patients with BMI more than 35 over more than 18 years with type 2 diabetes mellitus, and at least follow up at least 1 year. And if you look at the results, the remission at 1 year was slightly lower in sleeve patients compared to bypass patients. However, after the first year, these difference sort of decreased. And when the authors looked at the HbA1c stratified data, they did not find any significant differences between sleeve and the bypass, and the midterm outcomes were similar in both. So they concluded that there is an important role of sleeve, in remission of type 2 diabetes mellitus. But however, this remission was significantly more often observed following bypass, and hence bypass remains the gold standard. But if you read between the lines, after stratification of studies based on the definition of remission and duration of follow-up, no significant difference between sleeve or bypass could be observed. And therefore, the authors concluded that at this moment, there's no clear supporting evidence to choose one procedure over the other. This is a study from China which looked at predictive factors of glycemic control following sleeve or bypass procedures. And they included 17 studies involving more than 1,000 patients. And they also found similar diabetic remission rates with both short and long-term follow-up. And if you look at the one-year remission rates, it was 63% in sleeve and a bit lower in bypass, surprisingly. And if you look at the change in the HbA1c after both procedures until 5-year follow-up, it was similar. So according to this review, the predictors of remission varied between the two procedures. Among the sleep patients, the baseline BMI, the duration of diabetes, preoperative fasting blood sugar, and the A1C were important predictors of remission. However, among the bypass patients, only duration of diabetes and the preoperative A1C were predicting remission. So I would just, so the author said you should consider these factors while choosing sleep for a given diabetic patients. So, and our own analysis, for the lack of time, I did not include our own data. We had similar remission rates between sleeve and bypass at variable intervals of time. The median follow-up was 48 months. So we can conclude safely that sleeve gastrectomy can be used in obese diabetics. Diabetes is not a contraindication. However, we must, be selective, meaning thereby that we must exclude patients with poor preoperative glycemic control, that is a poor pre-op HbA1c, patients on insulin, and patients have a long duration of diabetes. These are the general rules of thumb we follow while selecting patients, excluding patients sleeve, and these patients are offered either a Roux-en-Y bypass or a one anastomosis gastric bypass. Thank you for your attention. Thank you.